So we're going to start by doing a first trimester scan. It might just be worth saying something about sort of where I'm sitting and things. I'm actually sitting on the side of the couch right next to our patient here. And the reason for that is that I find that it puts much less stress on my musculoskeletal system if I'm both close to my patient and also to the keyboard. So anyway, we're, I think, off now, so we're going to start doing a scan here. Just to show you first, this is a midline sagittal section of mum, so you can see bladder there. We might just change the depth for a moment so you can see cervix down the bottom of the screen there. And then we've got our fetus here. It's actually a little bit big for first trimester screening. It's actually 14 weeks, but we'll come back to that in a moment. You can see the placenta's anterior. You can obviously see the heart beating nicely there in the middle of the screen. So just because this little baby is behaving at the moment, we might start by trying to measure the crown rump length. So obviously, ideally, we'd want to make sure that the fetus isn't overextended, and we can look at the angle of the neck and also the gap here between the fetal chin and the thorax here to help us do that. Often with fetuses that are slightly bigger for first trimester assessment, you find the head is actually slightly out of sync in terms of alignment with the fetal thorax and abdomen. So sometimes it's actually surprisingly difficult to get the view that you want to measure a CRL. But here we're getting about 97 millimeters or so, so you can see that we're above the upper limit that we would normally use for first trimester screening, which is 84 millimeters. Just some other bits and pieces from a biometry perspective. So we're just looking at the head here in cross-section, and I think it's useful to get into the habits of just coming through the head, and I've just frozen here just to show you the posterior fossa that we saw in passing there. So let me just rotate the probe a little bit. Okay, so obviously want to get up to level where I can measure the BPD reasonably accurately. I'm a little bit oblique there, but just to give you some idea of where we're at. Can measure across there. Okay. Good. So in terms of aneuploid screening, the factors that I would want to examine include the nasal bone, and the fetus is showing us the nasal bone quite nicely in this area here. And in the first trimester, traditionally, we don't measure the length of the nasal bone. We look at the echogenicity and quality of the nasal bone. And you can see that it looks brighter than the skin edge above it. And we're reasonably midline here. You can see the skin edge both at the bridge of the nose and at the tip of the nose here. You can see, firstly, that I've just actually frozen here to show you the maxilla. And you can see that if we're exactly in the midline, that you get this sort of thin wedge shape. Whereas if I come a little bit more lateral, you get this extension here. So you can actually use this as a means of trying to make sure that you're nicely in the midline when you're doing this imaging. And that's the nasal bone there, and you can see we're in the midline there. So other markers for aneuploidy, obviously nuchal translucency. Now, this looks like the nuchal region here. I've got a reasonably large image, so I've got the fetal head and thorax here. Ideally, I'd, from a dynamic perspective, just want to see the fetus jump up and down a little bit so we can make sure that, firstly, we're in the right area, and secondly, that when the fetus is moving away from the posterior wall of the uterus, that the nuchal isn't enlarged. So we're just going to measure the nuchal translucency here, and you can see the echogenic line that is the boundary of nuchal translucency, both anteriorly here and posteriorly. And ideally, we want to place the caliper so it's on the bright echo edge rather than in the grey area. So that's one caliper there. This is the second caliper down here. And that would be a very normal measurement, 2.2 millimeters for this fetus. That's great. So just coming back through, we might actually just see if we can look at the ductal circulation. Let's just bring the zoom back up, actually. Yeah. Okay, so if we just put some color on now. Ideally, you want to look at the ductus with a reasonable angle of inclination. So let me just try and demonstrate that there. And do you want to just put a gate on? Thanks. See how we go around here. So I'm demonstrating quite nicely there two different waveforms on top of each other. So I suspect that's IVC that you're seeing there. And then the ductal was separate to that. So you see how easy potentially it is to make it look like you've got a negative A wave by planting one on top of the other. We'll just move on. We might just try and look at the fetal anatomy a little bit. So starting up at the head end again, we can obviously make sure that the cranium looks complete. So we can see that there's a nice bony outline there, nice echogenic bony outline to the skull. Other just basic features to check as we're coming through. First is that you can see midline development quite clearly, and you can see some symmetry there to development around the midline. As I've said before, we can then just work our way into the posterior fossa, and you can see development of the cerebellum here. In the first trimester, the posterior horn of the lateral ventricle is really quite large in relation to the cerebral mantle, and also the cerebral mantle, which you can sort of see coming around the edge here, has a very high water content, so you can see it's very lucent at this gestation. Just as we work our way down, it's good just to recognize the two orbits, and you can actually see the lens of the eye. You can actually just turn the probe round and do that in a coronal section, so you can see the two eyes there. And in this section, you can just also examine the face. And if Waldo was here, we'd be looking at the retromandibular space.
He is.
Oh, I'll behave then. And as we come down further, coming into the chest now, we're just going to change the setting on the machine. Okay, so just starting below the heart here, so just a reference point, you can see where the stomach is, below the diaphragm on the left-hand side. So we can see that we have a biventricular system, and, sorry, can you just reposition that? Yeah. That's probably better. Okay, so we can attempt to get a nice four-chamber view. Now the fetus is going to run away. What I might do is put colour on at an early stage, because I'll probably just be able to show you that colour is a very useful tool in the first trimester. So just coming down to the level of the ventricles to start with, So we can show that we've got biventricular flow, and then we can look at the left ventricular outflow tract that you can see going up there in red, and then if I keep on coming up, we get the pulmonary trunk coming down. And again, if I just flick the probe around a little bit, we can see those vessels coming in together there. That's a better example. So I think colour is very useful in the first trimester to help identify flow through chambers and also to make sure that you've got an appropriate crossover. And from a screening perspective, that would be all that I would do at this gestation. Let's carry on. So going back to the other setting, we can just continue to work our way down in this axial section. So we've come through the chest now into the abdomen, trying to just look at the cord insertion. If it's difficult in that plane, we can perhaps just change planes here. So you can see the cord insertion just there. Yeah. And if I just come back to my axial section, you can see that we've got a free vessel cord. Take the colour off again. Posteriorly, you can just see the two kidneys there. Bowel looks a nice normal colour to me. We can see the limbs, and being very careful to avoid anything else that might be in the area. Couple of feet down here, it's always useful. And then just looking at arms and hands, so just checking there's two bones in forearm. There was one hand that we could see there, that's the other hand there. That's great. Okay, so we might just switch away from looking at the fetus for a moment and just look at the Dopplers. So we've been talking a bit during the course of the last few days about other features that we might look at on a scan. You can see that the bladder's now quite full, and we can see the cervix quite clearly, but in reality, the length of the cervix now gets expanded by filling of the bladder. If we wanted to just come on to look at the Dopplers, if I start in the midline, I'll put some colour on here, sorry. Okay. And then just work my way, so I've rolled off the cervix laterally, and then I can see my uterine artery there, and I'm just trying to improve angulation. I'm trying to pick it up at the level of the cervix. You can see, come back to the midline, that's cervix there. Missed it. So we'll just measure the PI on that.
Are you angle correcting that, John, at any stage?
I haven't really. I mean, apart because the main parameter I'm interested in is the PI, which is a ratio, so I'm not so fussed about that. You could argue that you want to make sure that your PSV is over 60 centimetres per second, and there might be some benefit, therefore, in angle correcting from that perspective. But I did try and select a part of the waveform that was relatively vertical when I started. So, but you can see here that we've got a fairly nice waveform. And what I was going to do was just demonstrate a bit higher. So the PI here is 1.7 and our PSV is 117. So just do a little bit. If I try and take that vessel higher up, let's say here at the base of the lower segments, that's about 3 centimetres difference. So you can see now the character of that vessel's very different. If we just put the measurements on. So you can see as we've come more peripherally, the PI perhaps hasn't changed significantly, but certainly our PSV's much lower. And you do certainly see an increase in PI as you move away towards arcuate vessels. So it's really quite important to make sure that you pick up this vessel at the level of the internal cervical os.
You're on to the last minute, John. Is there any questions from the audience of things that they want to see that they haven't seen yet, or any comments quickly about while John's got probe in hand? Tricuspid regurgitation review.
Okay, we might go to cardiac again.
A quick peek at the TR.
We've sort of got a little contraction anteriorly, which isn't helping me. But so I'm trying to get the apex of the heart up at 12 o'clock. Yeah, just put a gate on that for me. And then what we're going to do is you can see the right AV valve, and we're going to put a gate across that. Yeah, just freeze it. So you can see that's the EA wave that you get with inflow through the tricuspid valve going up the screen. And we haven't seen any significant regurgitation there. Let's just take that off again. Just go back and perhaps just put colour on.
Have you moved your cutoff to 60, or are you still using 80 as a cutoff to consider tricuspid regurgitation?
I would tend to sit between those two figures, actually. I usually use about 75. The other thing that colour's useful for is often if you have regurgitation, it will be discrete. Actually, let's just put the gate just across the aorta as well as the valve. So colours, yeah, try there. Yeah, go on. Yeah. 1-0 to fetus at the moment. Yeah, let's go there. Okay, I was just trying to demonstrate that if you look at the left ventricular outflow tract as well, then you actually obviously get that waveform when you put the gate on as well. So we'll just perhaps bring the gate up there and let's see what we get there. So this is probably left ventricular outflow tract just here, not particularly good demonstration, but you can see that this is just coming down to about 30 centimetres per second, and it's usually quite pyramidal in shape, rather than being the sort of the higher flow rate that you get with tricuspid regurg. Okay.
All right, thanks, John. That's excellent. I think if everyone could congratulate John and the wonderful patient for that. Thank you.
Thank you very much.